Hello everyone, I am Dr. Rashid Hassan, founder and CEO of DentoScope Institute of Research and Advanced Dentistry, and also an associate dentist at DentoScope Dental Practice. Today we are going to talk about dental amalgam and dental composite, two of the giants of restorative dentistry. So let's get started. Well, the main objective of today's lecture is to compare the two most commonly used restorative materials in dentistry head on head. So, what we are going to do is that we are going to talk about the composition, the properties, the indications, contraindications, uses of all these all headings are going to be discussed for both of these materials, dental amalgam and dental composite. Both these materials, the restorative materials, are very much important from university point of view for your MCQs, SEQs, and for your Viva examination. So let's get started and let's talk about each and every heading one by one. Well, First of all, let's talk about the definition. How do we define dental amalgam and dental composite? What is the theoretical definition of dental amalgam? Well, dental amalgam is a metallic restorative material which is a mixture of silver alloy and mercury. Basically, dental amalgam is a combination of powder and liquid formulation. Well, the powder is the silver alloy and the liquid component is of mercury. We are all familiar with the fact that the mercury is the liquid at room temperature. So it is basically a combination of silver alloy, which has all the other elements as well, which we are going to see in the coming slides, and the mercury. So both these combine to give us dental amalgam. Now let's talking about the dental composite. Well, it is a highly cross-linked polymer material. Well, it is cross-linking is basically seen in the polymers. I told in my previous lecture on dental composite in detail that dental composites are basically a combination of polymers, fillers, coupling agents, and the activator initiator system. Well, if we talk about the cross linkage, well, that is seen in the polymers when the polymeric chains they come very close to each other and they get intermingled with each other, so they form a very strong bond with each other, and that's why they give strength to dental composite along with the filler particles, which also add up to all those strength. Now, coming to the next thing is the two distinct phases. Well, the two distinct phases in dental amalgam are the continuous phase and the dispersed phase. As I told you, that dental composite is a combination of organic component and inorganic component. Well, the organic component, the polymer matrix, that forms the continuous phase, while the inorganic component, which is the filler particles, they form the dispersed phase. So it is basically a combination of the dispersed and the continuous phase, and obviously there is a coupling agent which is used to combine these two phases. Okay, now let's talk about the composition. Let's see the composition of dental amalgam. As I told you, dental amalgam is the combination of the alloy, silver alloy powder, and the liquid mercury. So these two form the dental amalgam. So the alloy powder, the silver alloy powder, it contains the other elements as well, which are silver, tin, copper, zinc, platinum, and palladium. These are the major elements, the major components which are seen in the silver alloy powder of dental amalgam. And along with that, there are certain minor additions as well, but the main properties of dental amalgam is seen due to these all these elements: the copper, tin, silver, and zinc, etc. Platinum and palladium, of course, they give the grayish color to dental amalgam. Now, if we talk about the composition of dental composites, well, as I told you in the previous slide, that it is basically a combination of four major components: the organic component, inorganic component, coupling agent, and the initiator activator system. Well, let's talk about them one by one so you get a clear idea about what exactly these components are. Well, the organic component is basically a polymer. I told you that the dental composite is a combination of the two distinct phases, continuous phase and a dispersed phase. The continuous phase is due to the organic polymer matrix. The organic polymer, which is basically oligomer, is the main component of the dental composites. Now, talking about the second component, which is inorganic filler particles, well, these filler particles are basically dispersed in the continuous phase. It's just like you disperse salt into a glass of water. The water is the continuous phase, whereas the particles of the salt or sugar, well, they are the dispersed phase. So inorganic filler particles are basically they form the dispersed phase. Well, the important thing about the dental composite is that they are basically classified on the basis of inorganic filler particles. Inorganic filler particles, their particle size, their size distribution, well, that plays a very important role in the in the classification of the dental composites. Well, all the mechanical properties. There's another significance of dental composite, that all the mechanical properties like hardness, strength, viscosity, uh, and radiopacity, all these major mechanical properties seen in dental composites is only and only due to these inorganic component. These inorganic filler particles, they give all the mechanical properties to dental composites. Well, coming to the third component, which is the coupling agent. Well, the coupling agent, it basically forms a bond between a continuous phase and the dispersed phase. Keep this thing in mind, that the two phases, the organic component and the inorganic component, the polymer matrix, the organic polymer matrix, and the inorganic filler particles, well, they are not bonded to each other, right? As I told you that the dispersed phase, the fillers, they are basically dispersed in the continuous polymer matrix. So you are not going to get any of the mechanical properties if these two phases, if these two components, the organic component and the inorganic component, well, if these two phases are, if these two components are not bonded to each other, well, you are not going to get any of the mechanical properties of dental composites. So we need a bonding agent, a coupling agent, to bind the organic and inorganic part of the dental composite, and that is the saline coupling agent. Uh, Organosaline is the chemical name, but normally we call it as a saline coupling agent. And then coming to the fourth component of dental composite, which is the initiator activator system. Well, obviously, as we have seen it, that it contains polymer, and polymers need to get polymerized. So they can get polymerized by either chemical form or through a light source, right? So in order to set dental composite, we need to have an initiator activator system. The initiator system to initiate the polymerization reaction, and activator system to activate the active polymer sites in the dental composite, right? So initiator activator system is very much important in dental composite. Uh, as I told you, that they can either be get polymerized by the chemical reaction, or they can get polymerized through light. So in case of the chemically cured dental composites, well, the initiator is organosaline, the initiator is benzyl peroxide, and the activator is tertiary amine. In case of light cured dental composites, the light activated dental composite, there is a very, very important photoinitiator. Well, That's very important for your Viva point of view as well as for your MCQs, that there is a photo initiator in the light activated dental composite, and that is called as the camphor quinone. Camphor quinone is a light activated element, or you can say the initiator, which is present in the dental composite. Well, besides all these four components, there are certain minor additions like the color modifiers and the inhibitors. Obviously, you once the polymerization reaction starts, you need to control it, so you add certain inhibitors so that it stays controlled while you are doing your dental composite filling. Talking about the color modifiers, well, I told you in my last lecture. I will give the link of that lecture in the card, in the description as well, and you can go through that complete lecture on dental composite. Well, in that lecture, I told you that the color modifiers are added. These color modifiers, they give different shades to the dental composites. Like if you have seen the shade guide, it has different shades in it, starting from A1, A2, A3, then B1, B2, B3, C, and up till D. So the shade guide, the color shades, they transform from a lighter shade to a darker shade. The D1, the D shades, these are the darker shades, right? So once the patient comes to you, you check the tooth color by the help of these shade guides. You check the shade, and then the same shade is available in your dental composite. You take that dental composite and you fill the tooth for any cavity that is present on that specific tooth, so that the aesthetics is not compromised. So that's the significance of adding these color modifiers to make it more and more aesthetically acceptable. Now, let's talk about the classification. How do we classify dental amalgam and dental composites? Uh, well, talking about the dental amalgam, it is basically classified into three different types, and that totally depend upon the composition of the amalgam alloy. If we talk about the first one, is that is based on the copper content. On the basis of copper present in the silver alloy, I told you that silver is alloyed with different other elements as well, and one of them was copper. If you remember in the couple of slides back, I told you this. Okay, when we talk about the copper content, we can either divide the dental amalgam into two main types: low copper or high copper dental amalgam. Well, that totally depends upon the amount of copper in your composition. In low copper amalgam, well, the copper content is less than 6%, right? And in high copper, the copper content ranges from 6 to 30%. So that's the difference. The 6% is basically a borderline, is basically a demarcation. On if it is less than 6%, it is called as low copper dental amalgam. If it is more than 6%, and yeah, up till the 30% mark, you can call it as a high copper dental amalgam. Well, secondly, we can classify dental amalgam on the basis of zinc content. Zinc was also an important component in the silver alloy. When we discussed about the composition, I told you this. Well, on the basis of zinc content, either the dental amalgam can be zinc containing or zinc free, right? So, just like copper content, the percentage of zinc present in the alloy, the silver alloy, that defines either the dental amalgam is zinc containing or zinc free or non zinc containing, you can say. So, what exactly is that percentage? Well, if the amount of zinc is greater than 0.01%, you call that dental amalgam as zinc containing dental amalgam if the percentage of zinc is more than 0.01%, and if the amount of zinc is less than 0.01%, then you call it as non-zinc containing or zinc free dental amalgam. So that's the difference of this classification when it is based on the zinc content in the dental amalgam. Now coming to the third one, basically based upon the shape of the alloy particles. The alloy particles, the powder component of dental amalgam, what is the shape of the particles present in the powder content. Now, it can either be lathe cut or spherical, or the third one, which is admixed. Well, once you have done the you have made these components, you have just collected them, and then you have molten them to form one to take one form, and then you grind it. You can either use the normal lathe machine to grind those particles, and those particles, the lathe cut particles, are basically irregular in shape, right? So that's the difference between lathe cut and the other one. The spherical ones, well, in the spherical particles of the dental amalgam, the particles, they are shaped in a controlled environment, right? So that's why they get a spherical shape, which is a regular shape. I told you lathe cut, they have irregular shape. The spherical ones, they are manufactured, you can say synthetically, they are made, so their shape is very much regular. And the third one is basically a mixture of lathe cut and the spherical cut, the alloy particles. So third one, the admixed one, is basically combination of these two types of the particles. Now let's come to the dental composite. Well, based on the curing mechanism, we can classify dental composite into either light cured composites, chemically cured composites, or the dual cured composites. Well, the difference is in the chemical composition. In case of light cured composites, well, they are going to get polymerized. They are only going to get set by activation light. And there is the photo initiator, which I told you, camphor quinone is a photo initiator, which is present in the light cured dental composite. When you give it blue light, uh, well, the blue wavelength light that we use, LED light, has a wavelength of ranging from 460 to 490 nanometers, right? So this camphor quinone, which is present in the chemical composition of light cured dental composite, it has the tendency to start the polymerization reaction through light in the range of 470 nanometer, which is in between the range of this blue light that we use to cure it. So this is regarding the light cured dental composite. Now coming to the chemically cured, well, chemically cured are basically seen in the paste formulation. The two paste, one contains the initiator, the second paste contains the activator. And when these two pastes they are manipulated together, they are mixed together, the polymerization reaction starts. So the initiator is benzyl peroxide and the activator is tertiary amine in case of chemically cured dental composite. And the third one, which is dual cured dental composite, well, this is basically a combination of light cured and the chemically cured. So once the two paste mix, in case of dual cure, I'm talking about, when the two paste they mix together, the polymerization reaction starts, but not to the same extent as the chemically cured one, to a very lesser extent. Then the dentist, he or she has the liberty to insert it into the oral cavity, into the prepared tooth, and then introduce blue light. And once you introduce that LED light, the blue light of the specific wavelength, the camphor quinone, which is also present in the chemical composition of this dual cured dental composite, it gets activated. The final polymerization reaction starts. And finally, when you cure it for about 30 seconds on either side, for every 2 millimeter increment, the dental composite, the dual cured dental composite, they finally set. So basically, the dual cured dental composite, it has the chemical composition of both light cured and the chemical cured dental composites. Well, now coming to the second one, which is based upon the classification based upon the size of the filler particles. Well, on the basis of the size of the filler particles, we can divide the dental composite into conventional composites, small particle filled composite, microfilled composites, and the hybrid composite. Well, this classification is totally dependent upon the type of the size of filler particles. Now let's talk about them one by one. In case of the conventional composite, the filler particle that is quite large, about 50 micrometer in size. So it was the first dental composites to be introduced into the market for the aesthetic restorations. Then, due to this large particle size, there was a problem in the surface smoothness. The surface was not smooth enough. It was very rough, which causes the dental composite restoration to discolor after some time. So, for that purpose, the particle size was reduced to about 8 to 12 micrometer, from 50 micrometer to 8 to 12 micrometer. That's the range of the particle size which are used in the small particle field. Um, well, in these dental composite, the surface smoothness was slightly improved, and but the strength was a little bit compromised. Then the microfill dental composite. Well, these microfill dental composite, they have a very small particle size, zero point zero 0.01 micrometer particle size, which was very much less as compared to the conventional one and the small particles one. Then coming to the hybrid one, well, as the name suggests, we are very much familiar with this word hybrid. We have seen it in these automobiles as well. That hybrid automobile, it functions on both battery as well as on the gasoline or petrol, right? Same like this, in these hybrid composite, there are two different types of filler particles having two different particle size. One is the glass particles, and the second one is the colloidal silica particles, having the particle size of 0.04 micrometer. Right? So these are the four different types of dental composite, which are based on the size of the filler particles. Now let's talk about the availability of dental amalgam and dental composites. Let's compare the availability of these two. Well, if we talk about dental amalgam, it is available in three different forms. The first one is the most commonly used form, which is powder liquid bottles. The powder contains the silver alloy, silver as a major component, along with the zinc, copper, platinum, palladium, etc. And the liquid bottle, it contains liquid mercury. So this is the powder liquid formulation. The second type of dental amalgam which is available in the market is in the capsule form. Just like a capsule, you must have seen that it has two compartments. Same like those conventional capsules. One compartment has the silver alloy, and the other compartment, it has the liquid mercury, right? And there is a small metallic pestle present inside this capsule. So once we put this capsule into the amalgamator, the first thing the amalgamator does is that it presses, it squeezes the capsule so that the permeable membrane, a very thin membrane, basically it separates these two formulation, the liquid component and the uh, powder component. So it squeezes the capsule, the membrane present between these two components, it breaks. and those two components, the silver alloy and the liquid mercury, they mix together. And once the amalgamator start, the metal pestle which is present inside the capsule, it further enhances the manipulation process, the amalgamation process. It mixes the liquid as well as the powder component very much thoroughly. So that's about the capsule form, and rarely it is also present in the pre-weighed sachet form. The sachet form of the dental amalgam is also available, but it is very much rare. The most common is the powder liquid formulation, followed by the capsule form. The sachet form already weighed as per the requirements, but it is not commonly available. Now, talking about the dental composites, the syringe form and the paste space form. Well, there's difference between the syringe form and the paste space form. The syringe form is only for the light cured dental composite, whereas the paste space formulation is for the chemically cured dental composites or dual cured dental composites. So that's the difference between syringe form and the paste space formulation of dental composites. Well, now let's talk about the indications. Where can you use dental amalgam and dental composites? Let's compare them. Let's talk about the indications of dental amalgam. Well, the first thing is that it is used from moderate to large class 1 and class 2 posterior restoration. So it is a material of choice for the posterior fillings. Posterior restoration, with even if they are large class 1 and class 2 cavities, according to GV Black's classification, you can see the GV Black's classification on the cavities. I will give the link in the description, and you can easily go through that lecture and find what are the different types of the GV Black's classification. So, in case of large class 1 and class 2 posterior restoration, dental amalgam is indicated. Then class 5, when the aesthetic is not the concern. When in case of the class 5 cavity, which is present on the facial aspect or the buccal aspect of any of the teeth. If it is a posterior tooth, like a premolar or molar, well, if it is a class 5 cavity in the molar region, well, you can easily fill it with dental amalgam because it is not at all visible and it does not affect the aesthetics of the patient. Well, dental amalgam is the material of choice for the core buildup. Well, if the tooth is badly broken, it has large amount of caries. Well, what exactly do you do? That you remove the carious lesions, and let's suppose it is involving more than 2 or 3 walls of the tooth, then you are going to be left with a very small tooth structure. So, what exactly do? You don't waste that tooth structure, you just build the whole tooth. All around the tooth structure, with the help of the metallic pins, you insert the pins into the tooth structure and construct whole tooth. That is called as the core buildup, and amalgam is the material of choice for the core buildup procedure. Then in the episectomy, episectomy is a procedure. It is basically a surgical procedure in which we do the endodontics. We just remove the apex of the tooth, basically the interior teeth, and we fill it with dental amalgam. That is called as the retrograde filling. You just remove the flap and they expose the bone, and then you drill the bone, and then you reach up to the root level of the tooth that you want to obturate, and then you fill it from the root side with dental amalgam. That is the episectomy procedure, which will be discussed in great details once you are in your final year BDS. So from now till now on, you should have this concept that it is used to fill to do retrograde filling in the episectomy procedure. Then, in case of moderate caries control, well, if the caries are not that much spreading, well, dental amalgam can also use to control the caries lesion by filling. in any of the teeth. Uh, Mostly it is filled in the posterior teeth. You cannot fill it in the anterior teeth. Now let's talk about the indications of dental composites. Well, dental composite that is indicated in all the six classes of GV Black's classification of the dental restorations. Well, class 1, 2, 3, 4, 5, and 6. Well, all these cavities can be filled with the dental composites. Well, it is the major and most important material for the aesthetic dentistry. Well, it doesn't matter you're doing an anterior restoration from canine to canine, you are building up the tooth, whatsoever, you always prefer dental composite as the direct aesthetic restorative material. Well, in cases of veneers, well, veneer is basically a small, you can say it is much more thinner than the normal nails that we have. We just grind the facial aspect of the anterior teeth, and then we can give the veneers. So in case of the direct veneers, dental composites can be used. In case of well, veneers are always preferred in the patients which have discolored anterior teeth, which cannot be lightened up by the normal tooth whitening procedure, where in those cases we give veneers. And if we directly give veneer with the help of dental composite, that is that requires a lot of expertise. But dental composite is the material of choice for direct veneering. Well, in case of the some sort of accident, if the teeth become mobile and the patient bone is supportive, the patient age is even the patient is of younger age, and you can assess that the material, the teeth, they are going to get fixed after some point of time. What exactly do? You splint the mobile teeth with those with the firm teeth through dental composite, and after some time the bone deposition, it starts to occur, the osteoblast and osteoclastic activity, it starts to occur, and finally those mobile teeth, they get they stand firm in the arch. Now let's talk about the contraindications of dental amalgam and dental composites. Let's compare them. First, let's talk about the contraindications of dental amalgam. Where aesthetics is of major concern, well, we cannot use dental amalgam in the anterior teeth because that is not aesthetically acceptable. Lighter shade teeth, and you give a grayish restoration of dental amalgam, well, that's not going to help the cause. That's not at all aesthetically acceptable. Well, in the second thing is that excessive loss of the tooth structure. Well, I told you, according to GV Black, you have to make a specific cavity design. And one of these steps is the extension for prevention. You extend the cavity design to the normal tooth structure as well. You grind some of the normal tooth structure, and that's why there is some excessive loss of the natural tooth structure as well, which is not um, not at all acceptable, not even the ethically acceptable as well. But for GV Black's filling, we have to do it. So that's why it is contraindication in case of the massive loss of the tooth structure. If the tooth structure is already very much damaged and you prepare the cavity, you have to utilize some of the normal tooth structure as well. You have to grind that one as well. So it is contraindicated in the highly carious cavities. So in case of small class 1 and class 2 cavities, well, the small class 1, class 2 cavities, dental amalgam is contraindicated. Let's talk about the contraindications of the dental composites. Well, in case of the abnormal occlusal stresses, what could be the abnormal occlusal stresses? The best example of these abnormal occlusal stresses is the parafunctional habit. If the patient has some parafunctional habits like nail biting or the bruxism, right, or anything like chewing a pen or a pencil while doing any sort of work, well, these are the excessive stresses on the restoration. If the patient has those parafunctional habits, well, the dental composites are contraindicated in those patients. Secondly, poor oral hygiene. Well, if the patient has a poor oral hygiene, well, he is not at all suitable for any dental treatment, any restorative treatment, especially dental composite, because if he, that is, dental composite is basically used for the aesthetic reason, right? So if you prepare the cavity well, you make a very good dental composite filling, you do a very good filling, and then the patient is not at all bothered about the oral hygiene, his oral hygiene. He does not brush his teeth, he doesn't use these mouthwashes or whatever, he doesn't take care of the oral hygiene. Then after some point of time, that the dental composite restoration is going to get discolored. So that's why it is not at all indicated in those patients having a poor oral hygiene. Well, in case where the access is very difficult or the isolation is very difficult in the oral cavity, let me explain this thing. In case of, let's suppose, when accessibility is let's talk about the accessibility. If the caries lesion is present in the uh, distal end of the second molar or the third molar, right, the accessibility is very, very much difficult there, right? In those cases, you should not give any dental composite restoration, because you're not going to access that area even with dental drill. You're not going to be able to remove the complete dental caries, or even if you remove, you're not going to be able to insert the dental composite. So that is a very challenging situation. And secondly, when the isolation is a big problem, well, your isolation plays a very important role in the bonding of the dental composites. We will talk about this in the coming few slides, where I have talked about the type of bonding. But here I would just like to say that if the saliva, you are unable to control saliva and it is causing problem, you have to get the cavity that you have prepared is getting wet by saliva again and again. Well, the bonding is not going to be favorable. The bonding is not at all going to be good between dental composite and the tooth structure. So that's why in cases where the accessibility as well as the isolation is a problem, well, it is contraindicated in those areas. Then, if the patient is allergic to any of the component, obviously you are not going to give the dental composites. So, what are the merits or advantages of these two restorative materials? Let's talk about the dental amalgam. Well, if you talk about dental amalgam, it is easy to be used. Well, you don't require a lot of equipment for that. It is easy to use. You just mix powder in the silver alloy powder and the liquid mercury and use pestle and mortar, and there you go. Your amalgam is ready to insert. Well, it has high compressive strength. That is a very good very good advantage. That's why it is used in the posterior teeth, because compressive strength is very much important in case of posterior teeth. Why? Because in posterior teeth, the upper and lower jaw, the maxillary and mandibular teeth, they grind the food, right? They apply the compressive force on the food or whatever he's eating, right? So if your dental amalgam is not good under compression, if the compressive strength is not good, well, obviously the dental amalgam restoration is going to get fractured. So that's why we need that material which is good under compression, which is obviously the dental amalgam is. That's why you use it in the posterior teeth. Well, excellent wear resistant. It does not wear off. The anatomy that you have made while filling a dental amalgam restoration, well, it will retain its shape for a longer duration of time. So it won't wear off. It won't straighten. Then long-term clinical performance. Well, that's the plus point of dental amalgam. The clinical performance is, it ranges from years to years. from more than a decade, I would say. So that's why it was now, as we know that dental amalgam is not commonly used, but in clinical, in these preclinical practices where you do it on the phantom heads, uh, dental amalgam is still used, because there the teachers are the trainers, they are basically trying to teach you the exact cavity preparation. So there it is used, but it has high clinical performance more than any of the other direct restorative material. Self sealing ability is a big advantage, and I'll talk about it in the next coming slide. It is very much economical, it is cost effective for the patient as well, so he can get his tooth restored with a very less amount of money. Now let's talk about the dental composites. The advantages. First, the major advantage over dental amalgam is the aesthetics. It is aesthetically acceptable. We can easily fill the anterior teeth with the dental composites. Then the second thing is the conservation of the natural tooth structure. I told you for dental amalgam, we have to grind the natural tooth as well. Extension for prevention. We have to extend the cavity up to the natural teeth to prevent. For prevention means to prevent the recurrence of caries. But here in dental composites, well, we only remove the carious lesion, and we do not need extension for prevention, and we can easily fill the tooth with the dental composite. So the tooth structure is conserved. We do not lose the natural tooth structure. Then bonding to the tooth structure, that is also very important. The bonding is very much firm in case of dental composites as compared to dental amalgam. Um, Basically a micromechanical bonding. So I will also talk about this in detail in the coming slides. Well, same appointment polishing. Well, in the case of the dental composite, it is preferred to polish the restoration in the same appointment. You don't have to wait for some specific amount of time, like 24 to 48 hours to polish it. So you can do it in the same appointment, unlike the dental amalgam. Well, disadvantages. First, let's talk about the dental amalgam. Well, non being a non-aesthetic restorative material is a big disadvantage. It has all the good mechanical properties, but it is non-aesthetic restorative material. So that's why it is a very big disadvantage in case of dental amalgam. Well, talking about the conductors, it is a conductor of heat and electricity. It is a metal, it is a metallic restoration, and metals are good conductors of heat and electricity. So that's a big disadvantage, because whatever it's going to conduct, either heat or any electric shock, well, that's going to be diverted onto the dental pulp. So uh, yeah, just in case, just to explain this point as well, if the caries has extended from enamel to dentine and there is just pulp present underneath it, with the help of dental drill, you remove all the enamel caries, the dentine caries, and you have some amount of dentine present there. But underneath the dentine is your dental pulp. So it is dental amalgam being a conductor, it will easily transmit those heat and electricity up to the dental pulp and cause problems to the patient. Well, less conservation of tooth structure, because extension for prevention, I told you that we have to involve some of the natural tooth structure as well for a well done dental amalgam filling. Tarnish and corrosion. With the passage of time, tarnish and corrosion, well, tarnish is basically the discoloration of the restoration, and corrosion, we are all familiar with the corrosion. Is basically a degradation of any metal. So tarnish and corrosion being a metallic restoration, these are the big disadvantages of dental amalgam. And then obviously the galvanic shock, I told you that it is a good conductor. Being a metal, it's a conductor of heat and electricity. So if you remember the galvanic shock, uh, well, let me explain this thing. If you have dissimilar metals, let's suppose a patient is having an amalgam filling in the mandibular first molar and in the maxillary teeth, he has some other metal, the crown made up of some other metal. When these two teeth will come into contact, there will be the circuit completion. How? If you remember from your previous knowledge about the galvanic cell, one metal is a cathode, other metal is an anode, and there is a conductor medium which is water for the passage of the electric current. So here in the oral cavity, one metal becomes an anode, the other metal becomes a cathode, and saliva, it acts as the medium for the transmission of the electric current. And when these two teeth come into contact, the circuit is completed, and then a sharp shooting pain is experienced by the dental by your patient, which is very unbearable. So that's galvanic shock, and galvanic shock is a very big disadvantage in case of the dental amalgam. In case of dental composite, the disadvantage is the polymerization shrinkage. Well, as I told you that it is a mixture of the organic polymer matrix and the filler particle. The polymer is a very important component of the dental composite. And whenever there is polymer, there is going to be polymerization, and whenever the polymerization reaction will take place, the polymerization shrinkage is going to take place. So that shrinkage is a major disadvantage of dental composite. Well, it is a time-consuming restoration. It requires a lot of time as compared to the dental amalgam. The third thing is being expensive. The composite kit, that is much more expensive than the dental amalgam. It ranges about 8 to 10,000. One kit having different shades of dental composite. If you buy some hybrid composite, well, the one packing, it has different shades, but it costs about 8 to 10,000 as compared to dental amalgam, which is much more cheaper as compared to this composite. Well, increased coefficient of thermal expansion. Well, the coefficient of thermal expansion, well, this is a very, very big disadvantage in case of the dental amalgam. Sorry, in case of the dental composite, the large coefficient of thermal expansion, which is seen in the dental composite, well, it basically affects the properties of dental composite. Like if the tooth has a coefficient of thermal expansion and you fill it, I told you that always consider tooth as a material. So a natural tooth is also a material. It is a composite material. I told you in my previous lecture on dental composite that it is basically a composite material because it is also made up of organic component, inorganic component, and your water, right? So if there is a huge difference of coefficient of thermal expansion between your natural tooth and the composite, you fill it with composite. If there is some change in the environment, like the thermal change in the oral environment, well, that's going to cause expansion or contraction in case of the dental composite, and to that can lead to either fracture of the tooth structure. Now, difficult to finish and polish. Well, obviously, dental composite is a difficult material to finish and polish, and as compared to dental amalgam, because for this dental composite, we need some specific finishing and polishing burrs. The finishing and polishing burrs, the discs, the materials, well, they are only specific for the dental composites. Well, in case of dental amalgam, well, not much finishing equipment is required, and they are not at all difficult to finish as well. You can do the burnishing and use the finishing burr to finish, or polishing disc to polish the dental amalgam. So these are the disadvantages, the comparison of the disadvantages of dental amalgam and dental composite. Okay, now let's talk about the aesthetics. We are very much familiar that dental amalgam is basically grayish restoration. It is grayish in color, so that's why it is not used in the anterior teeth. It is only preferred, and what I would say, the best restorative material for the posterior restoration. Whereas dental amalgam, being an aesthetic restorative material, it is always preferred for the anterior teeth restoration. So that's the difference of the properties of aesthetics. And the tooth colored pigments, that the tooth colored modifiers, they are added to the dental composite, not to the dental filling. And the grayish color in dental amalgam is due to the presence of silver, copper. Copper basically is brownish in color. So tin, zinc, well, they give the grayish color to your dental, and obviously the mercury. So they give the grayish color to the dental amalgam. Now let's talk about the bonding between dental amalgam and the tooth structure, and let's compare it with the bonding of dental composite with the tooth structure. Well, the bonding of dental amalgam with the tooth structure is basically mechanical. It is basically a physical form of the bonding. It is only dependent upon the cavity design, the curvatures that you make in cavity design, the convexities in the walls, well, that define the dental amalgam bonding with the tooth structure. Because once the metallic restoration gets set, it cannot be dislodged. It is just like a very concave cavity, and you just fill it with dental amalgam, and after some time it gets fixed, and you are difficult to take it out. So that's how the bonding takes place in case of dental amalgam. And obviously you can use these pins, screws, so they also add up to the mechanical bonding of the uh, dental amalgam with tooth structure. So the bonding is mechanical in case of dental amalgam, whereas in case of the dental composite, the bonding is basically micro mechanical. That's the difference, mechanical and micromechanical. So micromechanical bonding is basically seen in case of dental composite. Dental composite does not adhere with the tooth structure itself. There's a specific technique which is called as the acid etch technique. The acid etch technique basically forms small micro holes by the phosphoric acid. The phosphoric acid, it forms small micro holes, and then when you add a bonding agent and then dental composite, the resin tags which are formed, well, these tags hold the dental composite filling. So that's why formation of these micro mechanical holes, the microscopic small microscopic holes by acid etch technique, uh, that gives it the name of micromechanical bonding. That's why it is called as the micromechanical bonding in case of the dental composites. Marginal seal. Well, dental amalgam has an excellent marginal seal with the tooth structure, whereas dental composites, well, they do not have they just have reasonably good marginal seal, but dental amalgam has the excellent marginal seal, and that marginal seal of dental amalgam with the tooth structure is due to, well, it is something very strange, that the disadvantage, the corrosion, which was the major disadvantage of dental amalgam. Well, the corrosive products which are formed, they basically seal the amalgam restoration with the tooth structure. These corrosive products, they form the marginal seal. So that's why it is much more close, or the sealing ability is much more better as compared to dental composite. Why the dental composite, they do not have a good marginal seal? Well, that is only because once the material gets set, it has polymerized, it is bound to shrink. It will definitely shrink, and it will somehow leave a very microscopic gap between the tooth structure and the restoration. So that marginal seal is not at all intact as compared to the dental amalgam. That that shrinkage will cause some the material will be somehow away from the tooth structure on a microscopic level, and that becomes an active site for the food lodgement, as well as for the micro leakage and recurrent caries as well, that can occur due to the polymerization shrinkage of dental composite. So that's the difference between the marginal seal of dental amalgam as compared to the marginal seal of dental composite. Well, let's talk about the mechanical property of hardness. Well, hardness, as we are all familiar, is the resistance of a material to indentation or scratching. Well, dental amalgam, if we look at these numbers, these values, Well, the Knoop hardness number of dental amalgam is about 100, which is always better than either microfilled or hybrid dental composite, which have the value of 30 and 90 Knoop hardness number respectively. So, dental amalgam by far is the hardest among the two restorative materials. Well, talk about the compressive strength. I told you that dental amalgam has an excellent compressive strength. It has good tendency to bear the compressive load of the mastication, the biting, the chewing. So that puts a lot of pressure on the restoration and the tooth structure, and the dental amalgam, as the value shows as well, 360 megapascals compressive strength for dental amalgam, which is much better than both types of dental composite restorations, either microfilled or hybrid. Hybrid being the better one of the dental composite, but still the compressive strength is less as compared to dental amalgam. Well, now let's talk about the tensile strength. Well, tensile strength of dental amalgam is not that good, but still it is much better uh, than the tensile strength of the composite. So both type of composite, microfilled and hybrid, they have the tensile strength values of 40 and 50 megapascals, and dental amalgam even has the better, although not very good as per the standards of dental amalgam, but still much better than the tensile strength values of dental composite, around 60 megapascals. Now, let's talk about the elastic modulus, the modulus of elasticity, which basically tells us about the stiffness of any material. So, if we compare the moduli of elasticity of dental amalgam with dental composite, well, the amalgam has the value of 30 gigapascals. 30 The elastic modulus is always measured in gigapascals, so it has the value of 30 gigapascals, which is more than double to the hybrid dental composites, which has the value of 14 gigapascals, and microfill, well, that is not at all in the comparison. It has just 6 gigapascal value of the elastic modulus. So now comparing all these values, we can say that dental amalgam is the stiffest of the two restorative materials. Now let's talk about the service life, the longevity of the two restorative materials. Well, let's talk about the dental amalgam. Well, dental amalgam, it has a proof track record for about more than 20 years prognosis in case of posterior teeth. Well, if we talk about the dental composite, a very well done dental composite restoration that will also need a replacement after every 7 to 10 years. That is the maximum time they can provide service in the oral cavity. That is a very large value of the number of service life in case of the dental composite. But dental amalgam, well, it has a proved track record of serving. Some filling lasts for more than 20 years. So this is the difference of the prognosis of these two restorative materials. So now let's talk about the conclusion of today's lecture. Well, we have talked about each and every aspect and all the major properties of these two restorative materials. Both are the direct restorative materials, which means that they can be filled directly into the patient's oral cavity. Uh, There and then on the chair side, we do not need any lab or technician to fabricate any restoration in the lab. So both are direct restorative materials. The difference is amalgam is non-aesthetic, dental composite is an aesthetic restorative material. Amalgam has high mechanical properties. If we talk about the compressive strength, the tensile strength, we talk about hardness, the modulus of elasticity. Well, all these values are much more higher for the amalgam restoration as compared to the dental composite restoration. Then we also talked about the sealing ability, the bonding. The dental amalgam has the mechanical, while the dental composite has the micromechanical. So we have discussed all these major properties of the both these restorative materials. So this lecture serves as a very good revision for both these restorative materials. And also we have started from right from the definition to composition, uses, advantages, disadvantages, indications, contraindications. So we have covered all the aspects of both these restorative materials. So me being an examiner of university for about 11 years, so I have this idea that which topic needs much more focus, and both these topics, that's why I have summarized both of these topics in one lecture, so a student can easily memorize or understand the difference of properties, as well as the uh, what you can say, the composition and the indication and uses of both these materials. So I hope today's lecture would be very much helpful for you for your preparation for your final examination for dental materials. If there are any questions, any queries, well, do not hesitate to write in the comment section below. And also, I would like you to subscribe to DentoScope Studio for more upcoming video lectures and other helpful videos on dentistry. Also, follow DentoScope on Facebook as well, on our Facebook official Facebook page, DentoScope Institute of Research and Advanced Dentistry, and also follow us on the Instagram. I am Dr. Rashid Hassan. Thank you so much, everyone, for watching. Take care of yourself. Allah Hafiz.